Muy buenos días, buen día, good morning. Bienvenidos al segundo seminario virtual de curso de
Good
vida.
morning, everybody. Welcome to this seminar. Today's topic is the practice of public health in a multi-generational society. I am grateful for the people and the participants who are accompanying us today. My name is Carolina Gomez. I am a specialist in healthy living here at the Pan American Health Organization, and I hope this seminar will empower all of us. Before beginning, I would like to ask you to take into consideration the following. We will have English, Spanish, and Portuguese interpretation. Please choose the language of your choice. There's a button at the in the lower part of your screen where it says interpretation. There you will be able to choose the language that you prefer.
Part of your Zoom screen at the icon globe. Esta sesión será grabada y posteriormente compartida.
This session will be recorded and then it will be later published in our website in the 3 languages. This is an informational seminar. We will be using chat for questions and answers. And we will be happy to answer any comments or questions that you may have. Now, I would like to invite Dr. Andrés de Francisco, who is the director of the Life, Health and Course of Life at PAHO for the welcoming remarks. Dr. de Francisco, you have the floor. And good morning, Carolina. Thank you very much. Good morning, everybody. Thank you to all the participants who are accompanying in this second virtual seminar on Course of Life on the practice of public health in a multi-generational society. For me, it is a pleasure to have this group of experts participating in this seminar who will share their experience in such a fascinating topic and also an important and new topic that has not been properly explored in the work in public health. For the first time in history, we have 5 and 6 generations living together. All of them are different among themselves and they have different needs and ideals. But despite their differences, their lives are closely linked and their decisions take place in an environment of constant change among generations. And because of this, these generations are closely linked. Today, just like at no other point in time, decisions have an impact on the course of life. This multi-generational structure in our society is duplicated in different economic and social and health contexts. So it is important to consider this for the formulation of strategies to be able to cover the changing needs of the population, especially because of the impact in health at the present time. We have to consider the important implications for the health and results in all of our populations. Right now, with the pandemic situation, we have seen very drastic effects on our societies. We had never seen this before. So this overlook and general overview of our new environment gives us a possibility for analysis, but also gives us an opportunity to contribute and continue in new courses of collaboration and social unity to be able to devise novel ways of cooperation. And then to find out what are the possibilities for the design of new health services for the population. Of course, public health is an important part of this effort. The theory of the course of life can contribute to change the way in which society considers all of these efforts by promoting actions designed to respond to different needs during the lifespan and then aiming at the development and well-being of all the populations. In this effort, it will be essential not only to transfer intra and intergenerational concepts. We have to consider inequality, we have to consider inequity and ill health in all of these. I would like to extend a warm welcome to all of you, and I hope you will find this interesting. We have an excellent group of experts who will be able to make a very valuable contribution to the work for the improvement of the health of our peoples. Thank you so much. Thank you so much, Dr. De Francisco. I would like to now introduce Mr. Max Friedman. Mr. Friedman will talk about the multi-generational structure of our society and why this is important for the work in this century. El señor
Collaboration across generational gaps. Mr. Friedman is a member of the Wall Street Journal's expert panel and frequent commentator in the media. He was named in 2014 as the Social Entrepreneur of the Year by the World Economic Forum, and he's the author of various books. His most recent publication, How to Live Forever, was published in 2018. Now I will leave you with Mark's presentation.
It's an honor to be part of PAHO's webinar series on the life course, and particularly this session on the multi-generational society and its implications for public health. And I thought, given the theme of the life course, I'd start by actually talking a little bit about my own life course in studying issues related to bringing the generations together. Even though I focus a lot on aging these days, I actually started out and spent the first 15 years of my career focused on young people living in poverty, trying to navigate their way through adolescence and to adulthood. And this was a time more than 3 decades ago where very little attention was being paid to the importance of social connections for young people, and particularly the potential value of strong ties with adults in the lives of those children. And this was quite striking because so much research on resilient children and young people who had managed to make it against the odds pointed to the value of these bonds. Emmy Werner from the University of California, Davis did a 40-year study of children growing up in poverty on the Hawaiian island of Kauai, and found, as she predicted, that despite grinding poverty and many other barriers facing these young people, that a group still made it. And what she wanted to do is find out what they had in common. At the top of the list was a powerful bond with a caring adult in the community. Sometimes it was a relative, a grandparent, an aunt, an uncle, a coach, a mentor. And Werner's findings have been reproduced and reinforced by so many others. Yuri Bronfenbrenner, the late Cornell child development professor who passed away a few years ago towards the end of his life, a distinguished career that led to co-founding the Head Start program here in the United States, writing dozens of books and hundreds of articles, was asked what he had learned from all this research. And he said, what every child needs is at least one adult who's irrationally crazy about them. So I very much taken with Werner's research, with Bronfenbrenner's insights. And it raised a question of whether you could help create these kinds of bonds and you get the same benefits with kids who weren't resilient in the traditional way, who didn't have the internal wherewithal to go out and recruit these adults. So got involved with others in doing the first study that had been undertaken of the Big Brother, Big Sister program in the United States, the largest mentoring program and the oldest here. It turns out we were able to do an 18-month study of 1,000 children on the waiting list for Big Brothers Big Sisters. 500 got mentors, and the other 500 waited for the 18 months. And at the end of that period, wanted to see the difference. And from a public health perspective, it was stunning. There was a 46% difference in kids starting to use drugs, a 50% difference in school truancy, a 33% difference in violent behavior between the young people who'd had a mentor and those who hadn't. And while we had no illusions that this was a panacea, it was really a stunning finding about the importance of these bonds and the ability to create them in communities. The unhappy part is that at that point, the Big Brother, Big Sister program was serving 70,000 children, and 30,000 children were languishing on a waiting list for 18 months on average. And that raised a question: if these kinds of connections could be so beneficial, where are the human beings to provide them? Where are the human beings to do the things that only people can do? And even then, decades ago, it seemed clear that one of the most promising places was the vast and growing older population. In the United States, that population was set to double over the next quarter century. And all the studies around use of time showed that the older group was the one with the most discretionary time of any population in society, and was largely overlooked. Big Brothers Big Sisters was recruiting primarily adults in their 20s, 30s, and 40s who barely had time to spend with their own children, much less 10 to 12 hours a month as a mentor for another child. So really curious about whether we could reproduce those results, tap the older population to play that role, and worked in concert with Professor Linda Fried, then at Johns Hopkins University, a geriatrician there who now is the Dean of the Mailman School for Public Health at Columbia. We created Experience Corps, which has been around now for 25 years, and happily discovered that there was enormous mutual benefit through connecting older adults in teams of 10 to 15, usually working 15 hours a week, to help mentor and tutor children in low-income schools in cities all around the country, and to focus on helping them read at grade level by the third grade. That program is now run by AARP in the United States. And at the end, and there's all the research from Johns Hopkins and Washington University in St. Louis, Professor Nancy Morrow-Howell there came in, underscored the powerful benefits. Another question came to the forefront: why does this happen naturally? Why do we even need programs like Experience Corps? I think we felt that we would always need programs like that, but there was the question of why this wasn't more organic, and that question became all the more profound as for me, as I started learning about human development in the latter part of life, after having focused on the first part of my career on human development in the first part of life. And to be a little facetious, I think that one of the things I've learned is that if young people need at least one adult who's irrationally crazy about them, older people need to be irrationally crazy about young people. Laura Carstensen at Stanford, the founder of the Stanford Center on Longevity, has a theory which she calls Socioemotional selectivity, which sounds very complex, but it's really a very straightforward idea that's been borne out in study after study by Carstensen and her colleagues, which is that as we move through life and the time ahead becomes less than the time behind, and shrinks further, we focus on relationship. We have almost an internal clock that we may not even be aware of, but to put a fine point on that, if someone tells you you have a month left to live in life, you don't decide this is a great time to go learn another language, or I think I'll take up a musical instrument. You focus on the people that you love and who love you, and on those relationships. And that I think Carstensen has shown convincingly that that's true in a broader sense as well. So as we grow older, we focus on relationships. And the good news is other research has shown that we get better at relationship as we move through life. Our knees may not be as spry as they once were, but emotional regulation, empathy, a whole set of skills that are critical for forging and sustaining relationships blossom through the life course. And for many reach their height in the later years. And the Harvard study of adult development, the 83-year longitudinal study, in many ways a parallel to Emmy Werner's great decades-long work on young people, in this case looking at happiness and well-being in later life, has shown that, first of all, that these relationships are critical to human happiness and thriving in later life. George Valen, who led the study for 4 decades, says happiness is love, full stop. And he goes on to show that there's a direction to all that connection. Older people who connect with, mentor, forge intergenerational bonds with young people are 3 times as likely to be happy as those who fail to do so. There's a best-selling book here in the United States, 10% Happier. Well, this is the 300% more likely to be happy. And Valen goes on to say this isn't just happenstance, it's deeply part of the story of the life course and of human development, of generativity. He says biology flows downhill. As we get older, it's a powerful instinct to connect with younger generations. Eric Erickson, the great life course researcher and theorist, said that the hallmark of successful development later life could be encapsulated in the phrase, "I am what survives of me." So with all of that knowledge from programs, from research, again, that question of why these bonds don't happen more commonly here in the United States. And I think I've come to the conclusion after many years of this work that they don't happen naturally because we made it very difficult for them to happen naturally. We essentially thwarted these kinds of connections in every corner of American life. We started in the United States, the 20th century, as one of the most age-integrated societies in the world, and we completed it as one of the most age-segregated. Professor Andrew Scott at the London School of Business, the author of the book, The 100-Year Life, describes the United States as being in a state of age apartheid. And I think there's some truth to that characterization. It wasn't a nefarious plot by any means, but we had a misguided notion of efficiency by age. So over the course of the first half of the 20th century, we segregated young people into schools exclusively with other young people, middle people in workplaces with other middle people, and older people in senior centers and nursing homes and retirement communities, and on, all too often exclusively with other older people. And the generational twains cease to meet. And it's no surprise in that context that we've essentially created out of all of this short-term efficiency a kind of grievous wound. It's probably no surprise that in the United States, in the state of age apartheid, that ageism is rampant, that there's a widespread sense of generational conflict. There is a vision of older and younger people locked in a zero-sum struggle over scarce resources, essentially interest groups. And loneliness and social isolation have been characterized as one of the most significant public health epidemics in America today by the current Surgeon General, Vivek Murthy. So we've got a whole set of problems that are linked to this segregation by age, and the timeliness of those problems is growing because 25, 30 years ago, the older population was predicted to double. Well, that's happened, and we're entering a point in our country where we already have more people over 60 than under 18. And we'll soon have 5 generations living simultaneously in a much more multi-generational future. So I think a big question is whether that future is going to be characterized by dysfunction and conflict, unhappiness and isolation, or whether it could be something much brighter. And I'm here to say that I have great hope that it can be something much brighter. There are some very encouraging trends against that backdrop of increasing segregation. Over the past decade in the United States, we've seen the fastest rise of multi-generational living since the 1940s. In our popular culture these days, television, film is filled with examples of older and younger people coming together. In fact, the top-selling jazz album in the United States and in the UK right now is the collaboration between Tony Bennett and Lady Gaga, with a 60-year age difference between them. But most of all, I want to focus on a wave of social innovation that's happening now in every sphere of society: housing, education, community living, social services, where talented social entrepreneurs are creating new ways to bring the generations together. One of my favorite examples is a home sharing platform that brings together older and younger people to share living space. Older people who have room to spare and could use help in daily living and with chores. Younger people, particularly graduate students living in high rent markets who need a break on rent. So it's born out of efficiency, but what happens, no surprise, is a lot of humanity, deep ties that form between the older and younger people. On university campuses, there's a wave of efforts to bring older people back to campus to continue lifelong learning. Well, it turns out that those start out in a kind of efficiency, but end up in humanity. At the University of Minnesota, the UMAC program brings fellows in their 60s and 70s back to campus for a year. And I remember a great story of a young undergraduate who was taking a future of work class and was wondering why there were all these older people in her class. And then by the end of the year, she realized it was because they had all worked. And so these deep exchanges happen there as well. I could go on and on about stories. One of my favorite is what's happening in Singapore around the idea of a kampong for all ages, kampong being the Malay word for village. The Singaporean government has spent 3 billion Singaporean dollars, I think about 2.3 billion United States dollars, to create a multi-generational village. Every new housing complex that's built is built around the idea of generational flats. Every new senior center or early childhood center that's built are co-located together to foster contact between the generations. They've built a vast volunteer corps of older people who are working to help young people thrive in every aspect of society. They're creating a new vision for what's possible. I think I'll close by just saying that if I've learned anything, it's probably these 3 lessons. First, we need a new vision for this multi-generational society. Rather than older people trying to be young, they need to be there for those who actually are. We need to be as creative in bringing the generations together as we've been in splitting them apart. And we need to move beyond some of the very promising pilots that I'm seeing all over the United States and really all over the globe, to a scale that's embodied by the Singaporean effort, or even some of the efforts that have been separating generations in this country for decades. I think if we do that, we can fix this problem. We can create a multi-generational society that works, that solves problems, that brings people together across divides, that creates a brighter future. And I think to that point, one of the most promising ideas, one of the ideas that I'm most passionate about, is not just bringing older and younger people together in ways that are mutually beneficial to help each other out, but in ways which are mutually beneficial, but also tap the complementary skills of the generations to help everyone out. I think there's some great potential. The assets and the skills of the generations fit together like pieces of a jigsaw puzzle. And so I think that's a solution just waiting to happen. So we can fix this, but I'd like to argue in closing that it can fix us. It can not just solve problems, not just be a source of efficiency, but of deep humanity. It can help resuscitate one of the most essential elements to human thriving, something that's been with us since the beginning of human history, and that we've been in danger of squandering. It's something that's reflected in every culture and every faith tradition, but I'll just finish with one illustration, a Greek proverb: society grows great when older people plant trees under whose shade they shall never sit. And I can think of no better benediction for making the most of the multi-generational future that's already washing over us. Thank you very much.
Bueno, muy inspiradora esta charla que Mark nos acaba de compartir.
Mark's words have been inspiring, and it shows the aggregate value of the collaboration, intergenerational collaboration, not only to fix the problems existing in different areas of society, but also to maximize the opportunities for collaboration and to see what humanity is doing around us. For the next session of our program, we will have 3 presentations that will be presented by several experts in our countries. For the first presentation, say a life course approach to epidemiology, I would like to introduce Dr. Ezra Sosa and Franco Maskajana.
Psychiatric epidemiology training program in Columbia University. His research focuses on 2 main areas. One is examining the role of early life experiences in health and disease throughout the life course, and the other is global mental health. Dr. Sosa is an editor in the International Journal of Epidemiology, lead author of the main textbook of psychiatric epidemiology, and former chair of the Department of Epidemiology at the Mailman School of Public Health. And Dr. Franco Maskajana is an investigator currently based at Columbia University, Mailman School of Public Health, and New York State Psychiatric Institute. So Dr. Sosa and Dr. Maskajana, the floor is yours.
Okay. Can you hear me?
Yes, yeah. We can hear.
Okay, I'm just going to share the screen. Okay. Oh, okay, well, I guess I'll, 1 sec, put it back on. Okay, can everybody see that?
Yeah.
Okay, great. Yeah. So Franco and I are presenting a particular example that I think is interesting from epidemiology. And for the broader perspective on life course epidemiology, at the end of the slides, there are what I think are the most readable and also fundamental books on this topic, if any of you are interested. But we'll focus on an example, and it has to do with very early antecedents of schizophrenia. So what do we mean by early antecedents? Really, they're exposures or factors that increase the risk of disorders in later life. So there could be a disruption very early in development. It could be before conception, for example, in sperm, but it's reflected in the fetus that's conceived. It could be in utero during pregnancy, or it could be in early infancy. But what distinguishes this from other kinds of conditions is that the disorder isn't evident at birth. It becomes evident in childhood, in youth, or in adult life, and sometimes even in late life. But we're going to talk today about a disorder that is usually evident in youth or adult life, and that is schizophrenia. First, I want to just give you the classic example of this kind of work so that you're aware of it. There was a drug called diethylstilbestrol, or DES, that was widely prescribed to pregnant women in the 1940s, 50s, and 60s. And it was thought to prevent pregnancy complications, although in fact—
Dr. Sosa, excuse me to interrupt you. Can you put your presentation in a presentation mood? We are seeing two slides at the same time.
Two slides.
Yeah.
I don't know why, but is that better?
If you go to the bottom of your screen, there is like a computer sign on the bottom of your screen on the right hand side on your PowerPoint.
Yeah.
So you can click there to make it like a presentation. No.
Yeah. It's never happened to me, you know, because I'm on a. I'm on a.
If you go where you were, put it in the way that you did before.
So.
Yeah, put it there. Yeah.
Put it there.
No, from the beginning.
No. Okay.
But now you go to the yes. Now you do it as you did. Just
now
next to the next to the volume, next to the Zoom, yes, bar on the left. There is a little bit on the left. There is a big go up.
Yeah.
I'm not finding.
Yeah. No. Open the presentation like you did. I will guide you.
Okay.
Yes. And yes. And now you say one thing.
Oh, now I see the three dots on the right.
Display settings.
It's on the top.
Yeah, I'm looking for it.
Display setting.
Yeah, display settings. Yeah.
Touch there when you say when
swap presenter view and slideshow.
Yeah, yes, correct. That's right.
No, but,
now we are on business. Thank you.
Okay, it's odd because now I see two on my screen, but you don't. But that's okay. Okay, good. So that works for you. Okay,
yes.
That's perfect.
Great. So should I go to where I was or start again? So I was here, if you followed up to that, and I was talking about the classic example of an exposure that happened during pregnancy, but was due to a drug that, a medication given that actually didn't work, but they didn't know that, and it was widely used. And it was first linked to vaginal cancer in the offspring, in the girls. And that was discovered accidentally, actually. I won't go into the story, but later it was shown definitively that taking this medication in pregnancy greatly increased the risk of vaginal cancer in the girls. And then later it was linked to many adult diseases. So that's the classic example of a medication in pregnancy that you couldn't see that it was doing any harm until the children reached adolescence or adult life. What we're going to talk about today are early antecedents of schizophrenia that have been studied in the same kind of way. And there are many: nutritional, infectious, toxic, social stress, and many other kinds. I'm going to focus on nutritional. It's a difficult thing to do, to relate prenatal experience to an order that doesn't show until adulthood, because these experiences may only be important at a particular time in embryonic development, sensitive times. And then you have to follow up for a disease like schizophrenia. You may have to follow up 100,000 people up to age 40. So it presents quite a challenge, but it has been studied in many different ways. These are some of the ways, but I'm just going to talk about one in the limited time, and those are natural experiments. And the way I think of a natural experiment is, the way I remember it, is that it isn't really natural. It's almost always a man-made disaster. And it's not strictly an experiment, because you don't assign people to their exposure or whatever, like you would in an experiment. But the key feature is that individuals have little control over their exposure, so that you can make the assumption or test the assumption that those that were exposed to this natural, what we call a natural disaster, are not very different than those that weren't exposed. And that's the key to the strength of the design. And we're going to talk about famine, and short-lived famines tend to be the most informative, because they can capture certain periods in embryonic development that are crucial. So you lose that if you have a very long famine that extends through the whole prenatal period and then into infancy. You don't know when is the period that's most important. So there was a study that was done of prenatal nutrition and schizophrenia. It was based on the famine that happened in occupied Holland. The Nazis occupied the big cities of Holland still toward the end of World War II. And this famine began in October of 1944. It got worse and worse over time as people got nutritionally depleted, used up the food supplies. And it was most severe in the last 2 months. And that's the ration that was given to the population daily over the last 2 months, not much. And it ended abruptly in May of 1945. That's the picture, the other picture. And that's very important because, you know, the cutoff, people were relatively well fed right after the day of liberation. So, so you can mark the end of the exposure, and then you can identify sensitive periods. So building on work that was done by my parents to establish Dutch famine study and others, I was interested in schizophrenia and neurodevelopmental disorders. So in my parents' study, they had found that there were increased anomalies of the central nervous system. We call them here CNS anomalies. And most of them were neural tube defects. So we reanalyzed the data to find out exactly when, during this period, were the CNS anomalies most salient. And it turned out that, can you see the pointer? No? Okay, well, it turned out that you can see where the bars are high, which is pretty easy. And that's the period October to December of October 15 to January 31st of 1945. And what you can see in that birth cohort, these are people born in 6 cities in the Netherlands, you know, the first half of 44, second half of 44. And this particular group are the group that were born from October 15 to December 31st. So you can see that there's a clear excess of 3 kinds of neurodevelopmental disorders in the same exact birth cohort. One are what are mainly neural tube defects, that's the black, and then schizoid personality, which was diagnosed in men, in the military recruits at age 18, and schizophrenia, which we got from the psychiatric registry in Holland, all admissions up to about age 45 years. So these people were born then, but when were they conceived? You have to make the assumption that they were born at term. And if so, then they would have been, most of them surely would have been. Then what this shows is that the exposed group, that's this group here, were conceived in the height of the famine. So they were conceived in like March, April, beginning of May. So, and then they had no exposure after that. So that defines it as an early prenatal exposure. And this is really a summary of a whole series of studies, but that was the end result, that we had 3 neurodevelopmental disorders, all occurring, those that were exposed only in the height of the famine and only in early gestation. So that result was just one study, and you can never be sure with one study. But after that, another group in China studied the Chinese famine, which occurred after the Great Leap Forward. That was a massive famine, one of the largest in history, and it happened after the Great Leap Forward, which was in 1958. So it happened from 59 to 60 was the height of the famine. And because this famine was longer, it's harder to pinpoint the time of gestation that was important. But because the sample was so much larger, this one province in China is many times larger in population than the whole of the Netherlands, you could get more precision, you had larger numbers for your estimates. So they based their study on what we found about early exposure being important. And since the famine was at its height from 1959 to 1960, they thought, well, those that were in early gestation in 59 and 60 would mainly be born in 60 and 61. And so that's what's shown here. You can see there's the births here, that's the fertility. And you can see the drastic drop in 1960, because fertility, births always go down during severe famines. And again in 1961, and then the rebound in 1962, which also tends to occur after a famine. And then you look at the risk of schizophrenia, and it's stable across all the other years, but it approximately doubles in these 2 years, in 1960 and 1961. So essentially, they replicated the results in a very different context. And then we joined together, and the first study was Anhui province, and we went to Guangxi province, to an urban area and rural areas. And this was a further confirmation, because the rural areas were the ones that suffered from famine, not the urban areas. And that's the opposite of Holland, where the urban areas, the cities were affected, but the rural areas had food. So what we found was the effect of the famine, similar to what I just showed, but it occurred only in the rural areas, not in the urban areas. So, you know, in these 2 very different contexts, you get the same result. And there are other issues I won't go into about that. But the main point is that you can get clues from these natural experiments that you can then study in more usual contexts in ordinary populations. And that's what happened for neural tube defects. So you had this increased risk of neural tube defects early in gestation in the Dutch famine study, as I showed you. And then there were cohort studies and case control studies, and most of them showed that folic acid in early gestation appeared to be preventive for neural tube defects. But the results were a bit mixed. You couldn't be sure. So they followed this with randomized controlled trials, and they proved definitively in these trials that folic acid supplements before 4 weeks of gestation, when the neural tube closes, do prevent neural tube defects at birth. Not all of them, but the great majority. So you can also do this in follow-up studies of neurodevelopmental disorders later in life. Doesn't have to be at birth, but it's often not feasible or not ethical to do randomized trials. For example, you couldn't do that for folic acid because we know that folic acid is beneficial. So you wouldn't randomize women to take folic acid or not during pregnancy at this point. So you have to find other ways. One way is, I'll just give you one example of the many ways, is to use a population-based pregnancy cohort. And these are large cohorts, often 100,000, sometimes 200,000, and they study a wide range of early antecedents, especially prenatally. They collect genetic data, biological data, and social data. And then they look at a wide range of health outcomes. And they generally include women enrolled in early pregnancy from a defined population. And then they have frequent follow-ups of the offspring into adulthood and often into the third generation. And they follow up the mothers and fathers too. So they become multi-generational studies. And one example of that is the Norwegian mother and child cohort study, which they call MOBA in the Norwegian translation. And it's a bit of a misnomer because they studied mothers, fathers, and children. And it was one of the first such studies to include the fathers. And they had a nationwide recruitment over a period of about 10 years, so that by 2009, they had more than 100,000 pregnancies. They'd enrolled 82,000 fathers. And the follow-up is ongoing. It happens every couple of years in different ways and for different conditions. And the children are now 12 to 22 years old, and they'll surely keep following them. They are doing so. But there's a problem with observational studies, including with pregnancy cohorts that I just showed, which is the problem of confounding related to healthy lifestyle. So if you have a health conscious mother, and that might be, health consciousness might be associated with many things, including socioeconomic status and cultural factors. But a health conscious mother is going to be more likely to take a folic acid supplement, and also more likely to have a positive impact on the child's development, or you could speculate that anyway. So if you were, for example, to look at whether taking folic acid supplements was related to schizophrenia in later life, you have this major problem of confounding. We found ways to solve this, but I'm not going to go into those. Just say that there are a variety of ways to minimize confounding. And there are ways to check that the result is not due to confounding. So you don't have to do a randomized trial. There was never a randomized trial of smoking, for example, but we know that it causes lung cancer and heart disease and many other things. And one approach to this we call triangulation. And that's when you use different designs and strategies that each have different biases, but they support the same result. These are just a few examples. I won't go into them, but the main point is that if you do have bias, then the best way to see if your result is due to bias is to do a different kind of study where that bias doesn't exist, but there might be other biases, because there's no unbiased study. And if you get the same result from these different approaches, then you can be that's very strong evidence for an effect. You can also use neurobiology to support the results. And there are plausible mechanisms for the effects of prenatal famine on schizophrenia in the offspring. And there are several plausible mechanisms. I'll just talk about one, which are epigenetic effects. And what are epigenetic effects? Well, if you think, yeah.
Sorry, I think we are almost done.
Okay.
We are, yeah.
Can I go 2 minutes or is it too much?
Yeah, I think so.
Okay, so this is just a schema that shows you that what you are, your phenotype, is not determined by your genotype. It's only partly determined by your genes, because your environment in utero, in pregnancy, will affect the way that your genes are expressed, and that's called your epigenotype. So both random things and your exposures change the way your genes are expressed, and then results in your phenotype. So in utero experience could have epigenetic effects that are related to the adult disease. And it has been shown that preconceptional exposure to famine has epigenetic effects. And from the same study, other studies based on the same exposure. And I guess I won't go into this because we're out of time, but I'll just leave these other slides with you, which are more general about thinking about the life course. And then this is probably the classic book that introduced life course epidemiology. And these are other books that you could reference. So thanks a lot. Sorry for going over time. We had this mix up with the slides. Okay.
Thank you so much, Dr. Sosa and Dr. Maskajana, for this interesting presentation. Ahora quisiera introducir a la doctora, a la licenciada
I
Zulma
would
Sosa.
like to introduce Zulma Sosa, who is the advisor with the Caribbean Center on Demographic CELAI and the Division of Population with CEPAL. She is providing support in the area of population and offering also technical assistance to countries on development and populations, such as the aging of the population, the demographics dynamic, and also international migration. Mrs. Sosa will be talking about intergenerational impact on health. I give you the floor. Thank you very much, Carolina. Good morning, all. Thank you, PAHO, for inviting me to be with you here in this meeting. Special greetings from the population section here at ECLAC, and from Simone Sekine, our director, and Alicia Bárcena, our executive secretary. Let me change gears, and as compared to the previous presentations, and I was asked to share with you the results of a study that we have carried out here at CEPAL on a methodology that is called National Remittance Accounts, and they allow us to quantify public and private transfers through the generations using trends and also data information that are typical of national accounts. I will be using a presentation. I don't know if you can see it. Yes. Thank you very much. As we have already heard, our region, as well as the world, are experiencing rapid populational growth, and we know that aging is one of the main phenomenon that characterizes this demographic change. And based on the estimates and projections by the United Nations, the group of individuals 65 and older and 80 and older are the ones that are growing more intensely. And these deep changes in the population imply also an impact on intergenerational transfers, public or private, that are controlled from the market and the family. So this focus on the remittance accounts that I have just mentioned also analyzes how individuals obtain and use the economic resources in each stage of life. This is the typical graph of the results of this analysis at the global level, that in this case is an average of studies in 10 countries of Latin America. And as you can see throughout the stages, the life stages, these in general use more than the revenues than they generate. In blue, we can see consumption throughout life cycle, and the red line represents labor income or revenue all through the life stages that also focus on productive ages between 20 and 50 years of age mainly. So what is it that we see here? We can clearly see stages and that individuals use more than the revenue than they generate from their own work. And this is something that we typically see in childhood and also in the elder years. And also the revenue generated exceed the needs for consumption, in this case, during productive ages. And this is the excess that we see, and we see the so-called deficit during the life cycle. To this end, it is important to observe that in terms of per capita analysis, this surplus is during the active period, and the main deficit is seen in the at later time in life, which is higher than the one that we see during childhood. For in all of the countries, the population that is 60 years of age and older is, for example, in the deficit stage, and they use 85% of their revenue, of the labor revenue. Now, when we observe how we see these transfers to cover the so-called deficit of the life cycle, these transfers are clearly seen in the public sector through investments that the states and governments are making, and also privately based on the expenses that the families generate.
Here in this chart, we can observe the flow of public transfer per capita through different ages. And then this is grouped in different classifications, such as education, which is here in purple. And here the investments goes from childhood to the young age, and then health, which is blue, and then of course we see other colors for other ages. So these public transfers are observed together with the importance of financing consumption for older people, especially because of pensions and also the increasing expenditure in health at an advanced age. When we analyze the financing of the deficit by per life cycle, per age, both public and private transfers, we see the deficit in the life cycle. And then what we observe here is that net public transfers are positive starting at 60 years of age. So starting at that age, people receive more than they contribute. And so this is an increasing trend with age. Also, it is important to note that people who over 64 years, people under 64 years of age also transfer funds to people over 65 years of age. So these people in the higher echelons of the age group are the recipients of these benefits. So the consumption in health, and especially public consumption for health, has to be taken into consideration when we talk about the impact on public expenditures, especially when we see an increasing population over 65 years of age. Of course, we see many diseases associated with different age groups. So we will see that as the population ages, some points of this demand increase. So regarding the impact on the aging of the population in health, we foresee a great increment in the consumption of health service, and therefore, this will represent a higher percentage of the GDP devoted to health. And within the framework of the aging of the population, we will be testing the sustainability of support systems to the family, the state, and the market. And this happens because we have an increasing importance of non-communicable diseases. And we know that in the elderly, we see the situation has been aggravated by the COVID-19 pandemic. So we see a great increase in care demands. In CEPAL, we forecast that by 2050, we will see a duplication in the number of people that need all of these benefits. So at the same time, we observe that the expenditure in health devoted to the elderly is gravely increased. So we see, because of the methodology used, that the proportion of the health expenditure devoted to the people between 2010 and 2070, we see a sustained increase in all the countries of the region. So this is a great challenge for care and for public policies and the improvement of the health services. And then we have to add that to the changes that we have seen in the demographic composition of the population. We see the increase in the number of elderly people and the changes in the relationships that we see a higher degree of dependency. So this relation between the population in under 65 and the population over 65 that requires care is an increasing trend. We see a great increase in the demand for care. And then this is due to the fact that we have seen an increase in this demand and also the institutions available to take care of this demand. And of course, the states continue to transfer this responsibility to the households. And then this, of course, this transfer causes situations of greater vulnerability and overburden of the work performed by women. So we see a context in which the families have a debilitating situation when they have this added burden of care of the elderly. women are, of course, the ones that carry the highest burden in this particular scenario. We, of course, want to call attention to the fact that we need a more decisive participation by the public sector. And we need better transfer policies in this scenario. Obviously, our region has a high degree of inequality, low coverage. We have deficient systems of social protection. And we also see many things that affect the health and the care of the elderly. So what can we do? Well, many countries of the region have already overcome the burden of the highest increase in the population. But most countries are already overcoming that part, and they are beginning to work in a negative growth environment when it comes to the population and the elderly in some cases, the care of the elderly. So we hope that we can timely implement public policies to be able to cover these populations. On the other hand, it is important to us to promote decent work and to improve working conditions. We have other opportunities that are being explored in the different countries, and that is the gender bonus. And what this means is an increase in the supply of female labor. And this allows us to cover some of the gaps and some of the inequities throughout the life cycle. And sometimes we see also an effect on income. But it is important to take into consideration this situation. And if we have less pressure on the younger populations for the demand of services, we have a window of opportunity here, and we can just create or conceive this care within a new dimension and analyze demand better. So in the long term, it is essential to make sure that the health services render universal care in a way that is shared with the state and with the households. Both male and female members of the household should contribute to that care. Thank you so much. Thank you so much, Vilma, for your presentation. The next presentation is Dr.
Advisor at the Pan American Health Organization. She has a specialization in maternal and child health and health promotion, a master's in public health, and a PhD in health education and disease prevention. Dr. Cafe also has a diploma as a counselor in sexual health and has worked for more than 13 years in PAHO at the country, sub-regional, and regional level. Dr. Cafe will be sharing today a presentation about risk communication for health. Sonia, el micrófono es tuyo.
Thank you very much, Carolina, and my congratulations to the previous presenters. Very interesting and productive presentations, and I'm seeing that yes, there we go. So yes, my papel for today is to make a brief presentation on the implications of public health practice in a multi-generational society applied to the topic of risk communication. And in this context of COVID-19, risk communication is, of course, a very important topic. We speak about it every day, we do it every day. But of course, risk communication does not only apply in emergency situations and with communicable diseases, but it is a public health practice that is essential when we try to apply preventive measures. And so the statement of today is that when we conduct risk communication in a multi-generational context, we cannot assume that one size will fit all. And as I mentioned, risk communication is it's a very core and important public health tool when it comes to primary and secondary and even tertiary prevention. What is risk communication? Let's first define what we all mean by that. This is a definition from the World Health Organization. Risk communication is a two-way and multi-directional communication tool to engage with populations so that they can take informed decisions to protect themselves and their loved ones. And risk communication and engagement are essential components of public health. And definitely when it comes to health emergencies, such as the COVID pandemic we are living in now. For public health engagement of communities, of subgroups, it is essential that they are facilitated to make informed decisions and to make positive changes in line with the information and the convincing that we are trying to do from a public health perspective. Now, if we want to convincingly and effectively implement risk communication strategies, there are a few things that we need to first maybe establish as starting points. First of all, for communication purposes and health communication purposes, the general population does not exist. We like to speak about the general population, but who is the general population? It does not exist. And definitely not if we are viewing society from a life course perspective. It means that we, in fact, are dealing with a lot of subgroups along the life course. And even though they may be inhabiting the same space, there is no such thing as the general population. Therefore, and this may sound like an open door, something very logical, but surprisingly, many times we do not comply with the necessity that communication messages and channels must be tailored to the specific subgroups. Even when the message content is the same, the way we target, the way we phrase, the way we package our health communication messages must be different. They must be aligned with the specific characteristics of the subgroup. Therefore, we need to use channels that the specific groups trust and that they can engage with. And again, it sounds very logical, but many times this is not adhered to. And I will elaborate on that a little bit in two examples that I will present. Now, what are some conditions? And these are theoretical as well as practical conditions for effective risk communication. First is we need to understand the risk perception and behaviors of each of the subgroups that we are targeting. And we need to understand their understanding and their interpretation of the information that is provided. And we also need to respond to their specific needs and knowledge gaps. we need to tailor our information, our risk communication to the circumstances of that specific group. And you might say, well, all of this is quite logical. This is, this seems like the basic rules of public health and of risk communication. Well, let's look at the example of COVID-19 risk communication. And from the perspective, what I'm going to share now is from my perspective as the Regional Adolescent Health Advisor, what I have seen happen over the past 2 years. First, when the pandemic hit, of course, all of us were scrambling to come up with a proper response, no? And so the first wave of risk communication had some key messages. One was that COVID-19 only affects older people. Younger people are not at risk. And as such, older people, especially those with underlying conditions. What was the result? That young people ended up not being compliant with prevention measures. And here I'm speaking quite generally, but that was a complaint that I received on my desk as the Adolescent Health and Youth Health Advisor. What can we do to make young people comply with the measures of social and physical distancing and wearing masks, etc.? It is true that they were less compliant because the first wave of risk communication had a specific slant, a specific packaging that did not take into account what the effect was and what the interpretation was on people across the life course who were not in the group of what we consider older people. Now we learned a little bit from that. And so in the second wave, what I call the second wave of risk communication, the messages became a little bit more diverse and a little bit more, maybe I should say a little bit more considered. The messages focused on that COVID-19, yes, that it primarily affects older people, but that young people needed to show solidarity to not transmit the infection to the older people in their home. That came already closer to engaging young people into the response to COVID-19, but was it meaningful? Solidarity is good, but how many young people would buy into this paradigm of solidarity with other more vulnerable groups? So what was the result? And again, speaking in a very general manner, young people were still not compliant with prevention measures because they did not feel that the messages applied to them, except for, of course, some positive outliers. There are always positive outliers, but is that enough to change the course of the pandemic, to change the course of any disease, of any public health challenge that we are trying to address? We don't want to depend on positive outliers. We want to depend on a core section or portion of the target population. Now, the third wave, which I would say we are in now, was a wave where we saw that the messages were even more profoundly diverse and trying to articulate the needs, the information gaps, and the demands of all age groups. And the key messages now that you hear are that COVID-19 profoundly affects all age groups. This is important, directly or indirectly, immediately or in the longer term. And so the different groups, of course, you still, and this message, of course, needs more detail, but at least it begins to engage the different age groups to say, hey, you are not an observer here. you are part of the issue and you can be part of the solution. And so we have been seeing in the second half of the pandemic, an increased compliance and engagement and advocacy from young people. This is just an example of risk communication in a multi-generational context where different generations, different subgroups might be affected in a differential way, and we need to therefore adjust our messaging, our communication strategies, our content to the specific groups across the life course. Now, briefly, let's look at the second example, because as I mentioned, risk communication is not only an emergency public health tool. We use risk communication in any prevention effort. And so we know the example of NCDs, right? Concepts such as lifetime risk become very important because NCDs, as we know, the risk factors, they accumulate across the life course. And what do we often see in practice? That when interventions focus on the groups with the highest risk, where the accumulated risk is the highest, which you would say, hey, that makes sense, but that's definitely not what we want to do, right? We want to make sure that, especially when we speak about primary prevention, that we address lifetime risk from the earliest time moment possible. Because let's give an example for a cardiovascular event. If we calculate lifetime risk at age 50, it's different than when we calculate it at age 20 or age 30. And that has implications, it has cost. And so when we focus interventions on short-term risk estimations, say 5 to 10 years, then our benefit, our public health gain is so much less than when we address them earlier in life. And this is just with NCDs. We can apply this type of reasoning to almost any public health challenge and say, how can we target and tailor our risk communication efforts for the largest benefit across the life course. So I don't want to take too much time, but these are just some illustrations of risk communication and the implications for public health in a multi-generational setting. So what are some final considerations? Interventions, any public health intervention, risk communication, or be it something else, must be based on a sound understanding of how health trajectories develop across the life course. And I think previous speakers touched on that. Most efficient and cost-effective interventions are those that impact on early risk factors and behaviors. We don't wait until things escalate. Conditions to effectively reach and engage subgroups include understanding their risk perception, understanding and responding to their specific needs and their knowledge gaps. Tailoring and segmentation are essential, and those are key concepts in social marketing, so I won't go into too much detail on that. Thank you for your attention, and thank you for the opportunity to be part of this. Let's just remember that one size does not fit all. Thank you.
Muchísimas gracias, Sonia, por tu presentación.
Thank you so much, Sonia, for your presentation. This is really interesting. And thank you so much for the expert for having shared your thoughts and your presentations, and for sharing your excellent ideas and experiences and the importance of risk communications and the implications at the multi-generational level in our society. And now, for our panel, I would like to give the floor to Dr. Betsabe Butron, who is the Regional Advisor on Child Care at PAHO, and she will be introducing the invited panelists. Dr. Butron, you have the floor. Good morning, everybody. Thank you so much for your invitation to moderate this session. We will have the pleasure of hearing two experts in two different areas. We will be listening to Pablo Ibarraran, who will talk about the conditional cash transfer and its impact on the social and economic conditions of families in countries in Latin America. And then we will follow by Jorge Perez Jaramillo, who will talk about community healthy settings for all ages. And he will center in the specific case of Medellin. So I believe we are short of time. I will give the floor to Pablo. He's a Mexican expert. He's the leader in the social protection area of the IDB. He works in strategic planning and development in the evaluation and oversight section. He's an economist. My apologies. Looks like my voice is failing. He's an economist, studied in the research for economic sciences, and he has a degree of the University of California in economics. Pablo, you have the floor. Thank you so much for your time and for being here with us today. Thank you. Please go ahead. Hello, good morning. Good morning, and thank you so much for your invitation to Dr. Vega and to the PAHO team. I think that this is a very important topic, very interesting presentations. And as Suma Sosa said, we will be presenting a different topic, but I think this is relevant and it has a great potential for the topic of supporting health through the life course from the perspective on social protection. So I will be talking about conditional monetary transfer, health and life course, which has been an essential tool for our work in Latin America, and this is a new approach. It has good possibilities for the topic that we are discussing. First of all, very briefly, what were the origins of the monetary transfer? They started in mid-1990s in Mexico and Brazil with two objectives. First of all, to provide resources to the poorest families to alleviate their poverty situation. And we think this is very important for health because of all the literature and the evidence that we have seen. But then also, we wanted to emphasize the reduction of the intergenerational transmission of poverty through the accumulation of human capital in children. So we wanted to invest money to make sure that all the children of pregnant women would go to health services, would have the care necessary, and also children would go to school to develop their capabilities so that they would have better working conditions in the future. So this is a long-term approach, and this is a multi-generational approach. So you see, the object of the programs is not to increase the income generating capacity of the households, but also just to help the families go ahead. This has an enormous impact in Latin America. They started in Latin America, and now they have extended to the entire world. In 15 countries, we have information. We have about 102 million beneficiaries in 2020. That's 20% of the population. And then it covers 60% of people in extreme poverty and 35% of people in moderate level of poverty. So this is an investment of about 9.5, 9.6%.
And the existence of those programs was very important because it facilitated for the region to have an important and significant answer to support the most affected families for the pandemic. This was the basis. It is also important to mention that these programs that we are mentioning today are projects that are geared towards not for structural shock, but for deep poverty, abject poverty. Now, how do these work? And we need to look at this from the point of view of health. On the one hand, these are programs that are focused on families that are suffering extreme poverty or moderate to severe poverty. And here we have two lines. One that is the line to access the program. That is to say, when they say we are going to accept families in situations of extreme poverty, but to leave the program, they need to overcome moderate poverty, not extreme poverty, or a vulnerability line. This is important because when they come into the program, we focus on the families that are most in need because it is fairer. It is they are the ones that need them the most. And this also has a greater impact on the families that are in the worst financial situation or economic situation. But to leave the program, one knows, for example, that if once they leave extreme poverty, they leave the program, they might fall back again. This is important because when one looks at the program, one may say, well, this is not for extreme poverty, this is a poor focus. That is not right because this has evolved. A second topic that is key is that we have co-responsibility in health and education. These are cash transfers. We do not like conditional cash transfers. We do not like the term conditional because it means that individuals are subject to doing something to receive the funds. But if the state will be requesting a family to send their children to school to receive the remittances, one has to guarantee that there is a school that is open, and that there are properly trained teachers, and that the services are good quality services. And the same happens with health. If we are going to ask for prenatal checkups and also postnatal checkups, we need to guarantee that those services will be available for individuals so that they can comply with these co-responsibilities. So we do like this term because it is something that goes both ways. And once the co-responsibilities are defined, the services are provided, it is important to verify, to process payments, and they're usually sent to women in the households. So once again, these are programs that support consumption and that try to improve the health and education of boys and girls in the homes accepting the remittances. There are several myths as to the remittance programs, and I always like to refer to these myths because oftentimes they are repeated and they become true. But for all of these, we have evidence that they are not true, that they are allocated based on electoral purposes, and it is not clear. We have conducted many studies, and since the criteria are very clear at the outset, we can say that, well, there could be a political intent, but it has never been clear whether they are used to price to those areas that have voted for a party, or in those areas where they didn't get the votes, we are going to offer the program in that area. I think it is important to mention that there hasn't been any evidence that there has been any electoral intent behind these programs. There could be a specific case, but this is not like this. Beneficiaries are not poor. This is not true. Most of the beneficiaries are individuals who are in situations of extreme poverty or vulnerability. And it is also said that they waste their money by buying alcohol and cell phone cards. That is not true. Through the surveys, we see that they spend on health, education, and better food. And it is not, we cannot condition them and say you can only buy this. Evidence is quite clear that the individuals that receive the money know very well how to use it and how to use it best for their families. It was we also heard that if the women received the money, the men were going to take it away, but it's not the case, because this also contributed to empowering women, and if these individuals will stop working just to receive a $20 remittance. No, that is not the case. And there may be cases, for example, in which the rule of the case is if someone is a formal worker, that person will not be receiving the possibility to participate in the program, then it is natural that the person will not want to obtain a job. But then we do not need to, we need to change the rule. And it is not true that individuals are having more children to receive the remittances. So these are aspects that need to be incorporated in the design of the program. For example, this is Panama. If we compare the expenditure of power subsidy and the subsidy to liquefy gas, and the subsidy that we have for the expenditure in opportunity network, 12% goes to the power subsidies, and then here we have 60% of the beneficiaries are poor and 28% are of the population is poor. So in general, for Latin America, 60% of the beneficiaries are poor, while 28% of the population is poor. So clearly, they are focusing on the poor population. Only 7% of the beneficiaries are medium to high class, or these are mistakes, but 35% of the population, and this is pre-pandemic, was living in a middle to high class situation. So the probability for a member of that strata of society to receive a subsidy like this is quite high because of the percentage, and also the efficiency. It is more efficient and effective to deliver cash as opposed to vouchers or food. We know that there is a greater chance of corruption, mistakes, and high costs when food is distributed. So administrative costs are lower, and we have also shown that there is better and increased consumption of foodstuff and nutrients by these individuals that benefit from these deliveries. And based on the evidence, remittances also help families to improve nutrition, health, and education. This is an inclusive mechanism. One of the benefits of the cash remittances is that they have been examined extensively. There have been several analyses from the operational point of view, and I will be focusing on health. There is a better use of the health services. The number of prenatal visits increases, the same as the number of deliveries at hospitals. And here we have a very important and significant challenge, and this is for these health services to be good quality services. And this is where we have some gaps. We need to have these services offer the proper quality to see the results, not only in the use of the services, but also in the health indicators that are the ones that interest us. We also see a reduction in child mortality due to causes related to malnutrition, diarrhea, so we obtain better health results. And in some cases, and this is, it also improves the size of the individuals based on their age. And in all of the cases that have reduced malnutrition, the use of these remittances is one very important element to be taken into account as a mechanism, as a social determinant of health to attain those results. And also something important, there is a reduction in the number of teen pregnancies. Cash remittances support the continuity of education, and the fact that girls can stay longer at school also open up several options and decreases the rate of teen pregnancy. And this is a key element in some of the countries of the region. The program has been devised to cover the whole cycle and the full course of life, from pregnancy, control of the healthy child, and then we can include other co-responsibilities and define other measures to promote better measures for health and healthy aging. in my opinion, how can we focus or how can we express cash remittances and the outlook of the course of life? So here we have to, these provide a comprehensive focus on health, nutrition, and education. This is not a specific intervention, but this is a cash remittance that goes hand in hand with messages and also support to the families. And that clearly changes from one country to the other to have that broad view. And we're interested in obtaining human capital, and that means health, education, and also obtain better get to have better development. And here we have the core responsibilities. And let me give you a health example or an example from the education sector. When the cash remittances started in rural areas, an incentive for the families was for them to send girls and boys to elementary school because there were some gaps in the coverage, but we heard not in the first 3 years of elementary school, but in 4th, 5th, and 6th grade, so that there is a gap and we're trying to overcome it. As time went by, that gap does not exist. So to have a co-responsibility measure defined in that area doesn't make any sense. In the case of health, if vaccination has already covered 90-something% of the population, to ask families to vaccinate their individuals to receive the transfer doesn't make much sense. The idea is to identify the gaps where we see the offer to close the gap, but we're trying to stimulate demand. So, for example, in the case of health, reproductive and sexual health in teens, we need to think how we can define measures so that families receive benefits, but benefits that are associated to health that we know that we can close important gaps. And this is something that we heard yesterday when I was talking to Dr. Vega, and you are experts in the area of health. So from the point of view of health provision, remittances have always been seen with some caution, and there are 2 or 3 topics to mention. First, most of the resources from those programs for the health sector, just because of course of life, have co-responsibilities in health that have to be defined from pregnancy to healthy child up to 4 and 5 years of age. And then we have also focused on them to be registered and to keep moving along in the school system. So pregnancy among 18-year-old teenagers clearly would not happen that often if they are mostly at school. But also in the educational sector, there is a tradition of offering scholarship and saying, well, for children to study, we are going to support families so that when there are costs for registration, for uniforms, for school supplies, and also for them to avoid to have to work. Oftentimes, the main cause for dropout is that children need to work. So if we offer an incentive, we can tell the girl doesn't need to work because we're going to offer remittance. When we move on to other levels, I have had the opportunity to visit several health centers, and many of the individuals there are not quite aware of why we need to have a program to offer money to the individuals for them to come to the health services. That tradition never existed. The idea is one has health services, has services that are provided at home, but there is no exchange. There is no monetization of the incentive for the families to have that. That is clearly a challenge. And if we can understand how to present this to obtain a better ownership by the ministries of health of these programs so that they can see it as a tool to stimulate the use of health services through the course of life, I think that would be key and very helpful. And there is a great deal of experience showing us how these remittance programs work. There is a flagship study in South Africa where the elderly receive remittances, and that improves the health of grandchildren. In South Africa, many times we had the missing generation was the intermediate one because of HIV. But we understand that in Mexico, they offer the universal pension for the elderly, and we also see similar pensions in other countries. This has been something highly important that has allowed us to stop to the problem and also focus on development in the region. The idea was to give you a brief outlook of the situation, and you have my email here. You can, the idea is how to use remittances in the course of life. Thank you very much for the invitation. Thank you, Pablo.
Muy interesante tu presentación. Creo que nos has dado no solamente la evidencia,
Your presentation has been very interesting. You gave us not only the evidence, but also the arguments to strengthen our work in health, education, and social assistance. I think that great progress has been made in the area of remittances, but how much could we do if we could work together to improve the quality of health services and also the quality of educational services, and see who the individuals are that, in spite of all of these efforts, still are lagging behind and they are more difficult to identify, and how we're making progress to move from services that are focused on vaccination, how we can broaden our scope as we have a change in the epidemiology of the society where we work. Thank you very much. You helped us, and you helped all of our participants working in the area of health to be more interested in these remittance programs, and also the same goes to our colleagues from the educational sector. Now we're going to move on to the last presentation. I am going to invite Jorge Pérez Jaramillo from Medellín, Colombia. He is currently advisor to the Antioquia governor on planning and habitat. He has headed the planning department in Medellín. He recently published a book on Medellín, urbanism and society. Thank you. It is a very interesting panel. I will be referring to the case of Medellín, my city, as an important study case that represents a great deal of the questions that we have in these organized societies. I think that Latin America is a great lab for this proposal. I am sharing a video. I don't know if you can see it on the full screen, that we prepared for the Seoul biennial. That is also, the idea is for you to see some of the geographical, natural characteristics of Medellín, and also to have an idea of where we work and also what we are promoting. As you all know,
padece una profunda, muy profunda crisis. Una crisis que llevó a que los habitantes viviéramos, digamos.
So here we have the inhabitants that living in the city, and the city in this situation would not be, if we didn't have the individuals here, would be situations of inequality, lack of democracy. If we imagine that situation, and also a crisis with the rule of law, that was the situation that in 1980 led us to a change. We could have said that this was a city of horror, but we were an expression of what we call a pandemic that led us to have a collective reaction, and this is something that we need to highlight. This was not something led by an individual. This was also the result of a society that out of the collective stress and post-pandemic built a reaction. They defined priorities. They understood that social dialogue was the path to follow, and the democracy in the region started in 1988, and we started to have this democratic process with the participation of the institutions. On the screen, you are currently seeing the diagram of the city, the planning, and how the river and the natural system of a riverbed that is very important, a river watershed that has several key areas that was destroyed, has led to a deep change. So I think that one could say that Medellin expresses a path of almost 30 years of search for a solution based on the communities, that key agreements had to be entered with collective mindset. So this is an important point of convergence of several generations. And I think that behind this recognized urban development that is recognized worldwide, I think that we should also mention that the city was developed through planning and through the different studies and projects. And they also developed a great capability to develop essential services with actions that focus on drinking water, health, education, public education, and also a methodology that led to the comprehensive improvement of the slum upgrading, or also social housing, different transportation offers, and social services, and the idea of building a city as a collective legacy and also as a scenario for public life. This also led to new leadership and hope. And I think that children, youth, women, the elderly, among many other citizens, discovered that social dialogue and the effort to build a project together gave room to hope and a reason to live. And I think that this is a key purpose. Life needs to be meaningful, and for individuals to live with basic decency, life quality, less poverty, and more public policies, more democratic participation. All of this contributed to reducing the rate of homicides and violence. In terms of health, we have the notion of the nutritional index of life that we have used to determine if our societies, if our communities with public policies and projects are improving their life condition and they have a more healthier life. The project that you are looking at is the final part of the video. Is quite important because it also implies a total change of the paradigm. We move from a city for machinery, cars, to a city that gives priority to recovering the river and also renovating public spaces, and in particular a city that is more integrated to give room to this, to a society that recreates its urban relationship with urban places, with the mountains, with the ravines, with the hills. And this would be this is the universal view of the Andean mountains that we have degraded a great deal. So as part of this discussion on public health and also on the condition of urban development, I think that one of our messages is that the city should be a great joint project, a higher purpose. Today, we are facing very difficult times, and I think that climate emergency, violence, and also globalization, as well as globalized inequality, as well as migration that has started to impact our region. All of this should show us how urgent it is in this urban world, and also in the hemisphere with the highest urban population. More than 80%, 4 out of 5 individuals in Latin America live in urban areas. We do need this new approach, understanding that our cities will be the essence of a healthy life. We have in this a great opportunity. Let me tell you that we have been working with Dr. Jason from Berkeley in the Institute of Urban Development, and Ms. Martinez from the Antioquia University, to try to understand this new relationship and territorial development, as well as related in relation to health. And we have also seen that there are very important components and elements for this and towards the future. This has been my presentation, and I hope it was a good contribution to what we have discussed so far. Thank you very much, Jorge. Your point of view is really fascinating. I think that we started with virtual seminar when we heard a great deal about human relationships and their importance, and now we concluded not only by underlying the importance of our relationship, not only to other human beings, but also to the environment, and also all the aspects that we share, and the benefits go beyond preventing some diseases. We have also focused on well-being, equality, dignity, and also living and participating in democracy. So I think that your approach must have been very thought-provoking and interesting for many of our participants, and we hope they are motivated to take those ideas and also, as Jorge mentioned, to get to know this experience a bit better. Now I am going to invite Dr. Vega to conclude the event. Please go ahead. Very briefly, I would like to thank you all. We are behind. I think that it has been a very enriching seminar. It has been a very important, nice presentation of the multi-generational society, the challenges and the opportunities that these societies have as part of a broad view towards this process that we need to face and how we can better do it. So I thank all of the experts for their kindness, and also for having contributed so much, having contributed their accumulated experience. And also I thank the participants for joining us in this new session that we just had on the vision of course of life. So we hope to see you soon. We look forward to having you in our next sessions, and see you later.